TopMedTalk.
In today's podcast, we're going to look at the importance of rehabilitation, prehabilitation, shared decision-making, delaying surgery, psychological optimization, and other ways in which you can provide value-based care. We begin with a conversation about the PrepWell project in the UK. This clip, featuring Professor Gerard Danjou, consultant in anaesthesia and sleep medicine at South East Hospital's NHS Foundation Trust, featured on TopMedTalk with Desiree Chappell and Geoff Lacey doing the presenting.
PrepWell is a health and wellbeing programme which we've modelled on cardiac rehabilitation, and we've integrated with the leads from cardiac rehabilitation at York University. And basically what we've done is transposed core elements of their model to the preoperative setting. And we're taking patients as early as possible who have evidence of unhealthy lifestyle behaviours, they're inactive, they smoke, they drink more than government recommended units, or their healthcare professionals just feel they would benefit from prehabilitation. We're providing a one-stop facility for a minimum of 4 to 6 weeks pre-surgery, where patients come in, they have supervised exercise twice a week, but they also have one-stop access under the same roof to smoking cessation, alcohol reduction and nutritional support. And we're also providing psychological support. There is also a yoga instructor and is into mindfulness.
Fantastic.
So we're able to offer kind of mindfulness support for patients preoperatively. We've got expedited diagnostics for patients who are suspected of having problems like obstructive sleep apnea. Obviously that ties in with my interest in sleep medicine.
Yeah.
That's known to be a cause for concern with surgery and adverse outcome. So traditionally, if somebody you thought at pre-op assessment had OSA, they may have ultimately a delay of up to 6 months before they could have their non-cancer or non-urgent surgery. We're able to do a diagnostic from the original entry evaluation and get patients on CPAP within 2 weeks. So that's cut a huge swathe of time out of that pathway. And it is patient-specific, population-specific, but the minimum time period that is thought to be effective is 4 weeks. But the important thing is the major benefits are made from being sedentary to mildly or moderately active. Right. So we're not trying to turn people into a Froome or a Wiggins here, however that might be done. Yeah. We're trying to get people to do some activity from not doing anything before. And that seems to be where the biggest benefits are accrued.
Avoiding the sedentary lifestyle.
Yeah. To start with, within PrepWell, we're targeting more complex or major surgical procedures because the risk of an adverse outcome is higher in those groups. But we've also, excitingly, got a grant from Sports England, and we're looking to scale this project up locally so that it's available on a stratified pathway to different patient groups. So not everybody will want to come to a gym before surgery. Yeah. So there may be park walks, there may be just use of green spaces and other things. And I'm working with public health representatives locally to really broaden this out across the local area. So we're really excited about that opportunity as well. For anybody interested in the GP toolkit, that's available at prepwell.co.uk. And if they go into Google and put South Tees PrepWell, they'll find some more information about the project on the hospital website.
The fuller conversation is available in the show notes.
We know that while these prehab exercise trials that have been conducted so far, they've been almost exclusively in hospital-based settings.
This is Chloe Grimmett, behavioural scientist from Southampton University.
So it's highly supervised in a hospital over a given period of time. And we know that despite the fact that there's really encouraging evidence there, we know that that's not sustainable in the NHS. We need some kind of alternative method for delivering these interventions, be it in the community or as a home-based trial. Now, acknowledging that, the Fit for Surgery team came up with this trial where they looked to start patients with a prehab exercise programme in hospital and then transitioning them into a home-based setting. So they start off in hospital and then they're given a programme to do when they're back at home. Now, the adherence rates for that went from 96% when they were in hospital and supervised to 8% when they went home, which was obviously a bit disappointing for the team, I'm sure. And also it's a case of, well, we know the patients are motivated. They're doing it in hospital. We've seen the qualitative evidence that they really feel the benefit of what's going on. So why the drop-off?
Chloe Grimmett works closely alongside the Fit for Surgery team, providing behavioural intervention, which is part of the West Fit Prehabilitation trial.
Now, I don't know how many of you have come across the Making Every Contact Count initiative, the brainchild, if you like, of Public Health England, NHS England and Health Education England. And it was their effort, really, to try and address this public health crisis we have of people having poor lifestyle habits. They developed, or an intervention was developed to support health professionals across the board, anyone who's interacting with patients or clients, to try and use those encounters as effectively as possible to try and promote behaviour change. Now, the crux of that intervention is something called healthy conversation skills. And that was developed by Professor Wendy Lawrence, who also happens to be at Southampton in the MRC unit. They developed this intervention that draws on behavioural science. So it draws on motivational interviewing, which some of you might have heard of, but most of all it draws on Bandura's social cognitive theory, which is essentially this notion of self-efficacy. That's the real core component of it. So if you can increase people's confidence and give them a real sense of autonomy over what they're doing, then you might have a better chance of them doing it. And this is really shifting the balance from being given an exercise program and told what to do, how to do it, and when to do it, to asking the patients what they want to do and how they want to do it, and to make sure they think about any barriers that might come up. So it's really about fostering this sense of empowerment and doing that through problem-solving, self-directed, graded goals and action planning, which in plain English basically means the person becomes a facilitator, talks to the patients about what they want to do, what are their goals. So it might be that someone just wants to get fit enough to get back to playing with their grandchildren or getting back to cycling, whatever it is that they want to be doing. That's their ultimate motivator. It has to be relevant to them in their day-to-day life. And they have to think about how they're going to go about doing that and think about what they're going to do if things get in the way. So the person delivering this training is asking a lot of questions and doing a lot of listening and doing very little directing. So it's all about encouraging the patients to find their own way. So the training itself is delivered in 2 half days, spread over a couple of weeks usually in a group setting. And these are the 4 key components of the training. So as I said, it's about asking open discovery questions, the how and what. So what do you want to do? How are you going to do it? What are you going to do when this happens? How are you going to deal with that? Doing a lot of listening, more than talking, and the people delivering the intervention are encouraged to reflect on the practices. So think about how it went, think about how the conversation evolved, how might they improve things moving forward. And it's really about supporting this goal setting. I'm sure you've all heard about SMART goals. It's about them being realistic, achievable, so that patients can start making small improvements and working towards these bigger goals. So in the context of WestFit, this has meant that the personal trainers who are delivering the exercise trial in the community setting are being trained in healthy conversations. So while they're having these one-to-one sessions, and there might be 2 patients exercising at a time, while they're doing that supervised element, they're trying to encourage patients to think about these things, think about how they're going to exercise on their own, think about what they're going to do after surgery and how they're going to achieve it. They might do some signposting as well to things that are available in the community, and they'll make sure that whatever the patient is planning on doing, it's safe and sensible as well within the context of what's going on.
Her fuller presentation is available in the show notes. This brings us to the occasionally thorny question of delaying or postponing surgery. It's a topic which became a heated debate in the UK's tabloid newspapers a few years ago, and is perhaps the most widely misunderstood aspect of perioperative medicine. This clip features, in order of appearance, Monty Mython, TopMedTalk's editor-in-chief, Jennifer Brandon of Hoag Orthopaedic Institute in Irvine, California, Desiree Chappell, TopMedTalk's lead presenter, and Shauna Butler of the Singularity University in Exponential Medicine.
We get a lot of heat in the UK because we've taken a view in certain places that if you're above a particular BMI, you should be given an opportunity to lose, over a period of time, some weight before you get knee replacement, for example. So what's been misquoted is if you can't lose the weight, it doesn't mean you can't get the knee replacement, but there has to be a window of time in which you have to be given an opportunity to lose the weight and therefore perhaps have less bad type 2 diabetes or whatever it is. Jen, what do you do in Southern California? Looking around here, I've only seen one morbidly obese person, right? Okay, to be honest, since we got here.
No, it's not true.
Okay.
It's not true. You're just looking in Newport. Orange County is Southern California is a large area.
Give me that one. So where you work, do you have to try and drop? Do you have to have 6 months to see if you can shed some of the weight? Or
no, we really don't. For our enhanced recovery program, we do have BMI baseline that to participate. Just because they're going home so quickly. And so we want to make sure that they're the healthiest that they could be coming into the surgery. But it doesn't preclude somebody from having a joint replacement surgery. It just means you aren't necessarily participating in our enhanced recovery program that is based on how long you're staying in the hospital. We certainly have people having joint replacements with BMIs in the 50s. And
with no window of opportunity to say, I wonder if we can get that down a bit before you get it.
Some of our surgeons do.
Okay.
It's for us, it's very surgeon specific.
Shauna.
I'm not sure how to comment on this because I'm not in a surgical clinical environment to really know what some of the policies are. I can go back to years in doing transplant. So part of that is that if you are smoking or any of these other types of things, there is no way we would give you and put you on that list of organ donations if you haven't made the lifestyle changes that really make sense to give you that precious organ. I'm not sure if I can.
With all the innovation, though, don't you think that the innovations, the wearables you referred to, all of those different things, couldn't that add a huge amount to people just grasping those few months to see if they can?
Absolutely. So from the standpoint of engaging the types of encouragement, the assist, the technology, the information to help people have a more successful outcome, clearly, if we get people down to a healthier BMI or a less healthy BMI before they go into surgery, on every single metric where we've got a successful surgery and a successful outcome being at a healthier weight. So there's no there should be every incentive to have that happen. But at the same time, one of the really interesting challenges is if you are so uncomfortable, you can't move because you've got so much pain, it makes it really hard to get that weight down. Sure. So if you remove some of the pain, but one of the areas that I've seen be really successful is how do we use swimming? How do we use yoga? So they're really a good piece of prehab. And the other piece that people are missing out on is meditation and mindfulness. So using that, that's pretty low tech and pretty high as far as outcomes and improving. If that's all, I love what John Kabat-Zinn talks about. If you're breathing, you're doing something right. Let's start from there.
You have to have a starting point. In Kentucky, I don't know if all of our patients are always even breathing some days. So I think for us, that the transition from how we're reimbursed still so affects the patient selection.
Well, yeah, I was just going to say the big difference that you've got there is you have a national insurance, so they are on the hook for the bill, and they're in line. They're the incentives as far as having a proper outcome, and then who gets selected and what the criteria are. You have a centralized approach. So that's, again, maybe one of the benefits or the upsides of the type of financial model. And the interesting thing for me, looking at the economics of how we deliver health across the globe, is that every single society has to make some important decisions. So what I've said is that, or what I've found is that there's no system out there who gets it completely right. And there are no easy answers. There are just really difficult questions that as a society, we need to figure out where do we want to put our dollars, where do we want to put our resources for the outcomes that we're willing to achieve. And so that's again, the UK has really tackled this on all of the criteria around their surgeries. And most countries that have a nationalized health insurance program, it's along the same lines of whether or not you're going to get cardiac surgery, you're going to have certain diagnostic tests. They're looking at the value of doing that and what conditions and criteria are we going to set so that we encourage people to be their own best advocate.
Yeah, and I think it's a fascinating conversation to have. And honestly, as a practitioner in the OR every day, I work 40 hours a week on the stool delivering anesthesia, and I ask these questions every day. Why are we here? What are we doing? How are we going to improve outcomes? Does this patient actually meet a criteria that is acceptable for us to be doing surgery today? And I think as long as we are looking and working it through the dogma and the traditional fee-for-service care and not looking at what value is and what quality is and ultimately what outcome is for our patients, that we're still going to always kind of struggle with that question. So,
aren't you all worried that you spend more money on healthcare than anyone else and life expectancy is going down in the USA?
Absolutely.
How do you rationalize that?
I'm not sure that you rationalize it. I think what you need to be doing is looking at it and understanding it and figuring out why it's going in those directions.
It's going down, isn't it?
It is.
Yes,
it is.
Absolutely it is.
And this is where we talk about your zip code says more about indicating what your health outcomes will be than your DNA. And
Come to Kentucky.
Yeah. So I think that the interesting piece about this is that we, a phrase right now is the social determinants of health, that we are looking at your economic, your geography, your educational attainment, all of those pieces impacting your health. I'm not a real fan of using the word social determinants. I like social influences, because when I say determinants, it makes it feel like it's a foregone conclusion. I can't do anything about this. When we understand that these are the influences that influence either really good health or really crappy health, then we are able to, from a systems design, understand that if you don't have clean water, if you don't have safe sidewalks, if you don't have street lights, if you don't have clean air, if you don't have good schools and education and financial and economic opportunities, your health will suffer. And at the end of the day, when you're talking about particularly obesity, if I don't have a roof over my head, if I don't have food in my belly, if I don't feel safe and secure in my environment, if I'm not warm, any of those basic things, I don't really care what my insulin level is. I am in that pure survival mode. So if we really want to, I think so how do you rationalize this? I don't think you rationalize it and say that it's okay or this explains why we're doing it. I think it's really indication of what are the things that we can do to turn this situation around. Because when we're seeing these metrics, what are the factors that are forcing this into being? So no, I don't think you rationalize it whatsoever. I think you look at that and you make some course corrections quickly.
Yeah. No, and I think and before we wrap things up, we talk about a systemic approach, but again, when you're looking at on the ground, and Jen, you can kind of talk to this, it's a different picture. What the expectations are, what I can actually achieve versus what the expectation of what I can achieve is. And so, do you deal with that with your patients?
Well, I think you can set all the expectations that you can, but you can only change what you can change. So you just do the best that you can and try to put the best supports in place for people to make those changes so that they come into the situation, in our case, a surgery, for the best possible outcome that they can have.
Yeah. The fuller conversation is available in the show notes. Right at the heart of this debate is a core concept.
So my topic this morning is shared decision-making.
This is Angela Coulter, a UK-based health policy analyst and researcher.
And here's a definition in a report that Alf Collins and I published for the King's Fund. Clinicians and patients working together to select tests, treatments, management or support packages based on clinical evidence and the patient's informed preferences. Many of you will be familiar with the concept, but in case some of you aren't, it's important to recognise that what it's about is essentially a meeting between experts. The clinician, of course, has been to medical school for years and years and has amassed a great deal of experience on these things. The clinician knows about the diagnosis, the likely prognosis, etc. But the patient also has an important body of expertise which is not available to the clinician unless they have a good conversation about it. The patient, and only the patient, knows what it's like to experience the illness in their particular social circumstances. They, and only they, know about their values and preferences and attitudes to risk. So to make a good decision, that is if you have time, and of course there are some situations, emergency situations like some of the ones we were just hearing about, where it isn't possible. Time may preclude this kind of discussion, but where it is, and that is true of most medical decisions taken every day, the idea is that you should bring these two sources of expertise together. And my colleague Al Mully has written a great deal about this, including another King's Fund report by him and his colleagues, which talked about the problem of misdiagnosis, the silent misdiagnosis. And they argued that if patients are unaware of the treatment options and outcomes, what's known about the risks and benefits, and indeed the uncertainties, and the clinician is unaware about the patient's preferences and values and attitudes to risk, then inevitably what you have is poor decision quality. So what we're talking about here is trying to improve the quality of clinical decision making. And it's been discussed and indeed written about quite extensively over many years. And here's a simplified model of what the shared decision-making discussion, at least in theory, is supposed to involve. And one problem with this model is it looks a bit linear, and it isn't always like that. But still, the patient needs to understand that there is a choice. And in most cases, there is a choice. Sometimes there's a choice between different treatment options. It may be even just a choice between two different drugs. It may be a choice between drugs or surgery and so on. It may be, and often it is, a choice between having an intervention and not having an intervention. So the patient needs to understand that. Then they need help to think through the various different options and what they might mean for them. And then they need a collaborative process in which together clinician and patient share information and make a decision. Now here's another way of presenting it. First of all, patients have got to be invited to participate. And for some patients, this may be quite surprising because we're all brought up to think that, we go to the doctor's the expert and the doctor makes all the decisions. But increasingly, that's changing. And it needs to be explained to patients that their views are important. Then the options have to be presented, information on benefits and risks, a weighing up of those options, and I'll talk a bit more about that in a second. And the patient needs help to sort of deliberate, think through those options. And then finally, the clinician's job is to be responsible for making sure that whatever they've jointly agreed actually happens. Now, here's an example of the kind of trade-offs that are quite common, particularly in patients who may be scheduled or may be thinking about elective surgery. In many cases, I'm thinking about common operations like prostatectomy or hysterectomy. There are sometimes patients who know that these may well not be life-threatening conditions they're suffering from, may need to be reassured that lifestyle changes might make a difference, or medications alone, or indeed other interventions, or surgery. So this graph shows you the likely effectiveness of each of these, but we also know that the side effects tend to rise in proportion to the effectiveness. So sometimes patients have really quite complicated trade-offs to make, and they need time to think about these and to come to a reasonable decision in conjunction with the clinician.
Steve Flanagan now, the Chair of Physical Medicine and Rehabilitation at Roscoe Rehab, NYU.
Part of my job is to make sure that rehabilitation is playing an important role in achieving the triple aim of medicine, which is to improve patient care, improve their outcomes, improve their satisfaction, but to do it more efficiently, which we all know is a euphemism for less money. We're getting folks up, we're getting them mobilized. We believe that exercise is real medicine. When you mobilize patients early on in their hospital course, even if they are in the intensive care unit on a ventilator, you are effective in decreasing their length of stay, decreasing their need for post-acute care services, saving money, improving outcomes. We were very successful in the ICU. We were very successful in the acute care floors as well. So when we were planning for the bundled care initiative for the pilots, naturally the hospital realized the value that we bring and made sure that we were involved. So we increased the amount of rehab that folks were getting after their operations and oftentimes providing their very first therapy session in the recovery room. And after that, making sure that even when they're not on an acute inpatient floor, they're still getting therapy twice a day. Because the evidence will show the more they're exercising, the quicker they get out, they're getting out healthier, less money, and they're staying out longer.
Mm-hmm. You've been transitioning to the value-based care model, and you're a pilot program for that. What's that transition like, though? What have you found?
So there were a lot of transitions that we needed to deal with. In the past, there was a very heavy reliance on IRF, inpatient rehabilitation facilities, including RUSC, or inpatient service, to treat those postoperative patients, whether they were in the bundle or not. And we realized that that constituted a large cost of the postoperative care or the post-acute care, and that just simply wasn't going to happen anymore. So we had to go through what could have been a painful experience of shifting our services, moving our docs into more of an acute care right after the operation, providing consultations, and moving some of them over into a subacute partner to make sure that we were providing RUSC high-quality care in a subacute facility, which is very different than an IRF or an inpatient rehab facility. So there was a little bit of pain with that because there was a contraction of our number of inpatient beds. But it's also really a cultural change, and the reason why it was ultimately successful is that there was a culture in the hospital that supported that. They recognized the value that rehab offered, but they also worked with us from the very beginning to make sure that that value that we offer is shifted from a very expensive IRF model, which for some patients is still very important, but shifted that to an acute care service, to subacute, and also to make sure that we were providing services in the ambulatory side. So once those patients were discharged, we made sure that they were discharged to a RUSC physical therapy center so that it kept it in the family. We were able to provide not only their high-quality rehab, but we were also able to identify problems early on, report it back to the surgeons who were in our system to make sure that we identified problems early and helped to prevent readmissions. So it was my belief that we went through the entire continuum of care, and in some instances we even provided rehabilitation, making sure that we were involved in their care beforehand. And I think one of the important things, particularly with folks going for surgery and preparing for what's happening next, is to really educate the patient. This is what's going to happen. You're going to have your operation, but expect that your first physical therapy session may very well be in the recovery room so that they're not shocked when they're being told to get off the gurney and exercise. Also expect that once you're on the acute care floor that you're going to get physical therapy or occupational therapy at least twice a day, and that's going to go on for a long period of time. So it's really setting the expectations. And when you have the entire team and the entire culture of the institution, the team, promoting that, it becomes a little bit harder for the patient, the couch potato, so to speak, to say no. You won't be able to motivate everybody. We just have to accept that. But boy, we can be successful with more people if everybody buys into it, and it's the culture of the team and of the institution.
TopMedTalk.
Thank you for downloading TopMedTalk. Today's TopMedTalk contains lots of conversations which you may want to enjoy in full. Click now onto the show notes for this podcast and find links to all of these pieces that we've been enjoying parts of. www.topmedtalk.com for more details on this podcast. And don't forget, of course, TopMedTalk is the broadcasting arm of EPOM, Evidence-Based Perioperative Medicine. EPOM have been pioneering world-leading conferences on the subject of perioperative medicine for many years now, and we'd love you to find out more about them. Please check out epom.org for more information.